Okay, everybody, thank you very much. Apologies for the very short lunch break, but please, like myself, enjoy your lunch during this next speaker's talk. So the next speaker we have is Dr. Nilafor Noor. She's one of our lovely colleagues in Derby Hospital. She's a very senior obstetric and gynecology trainee, and she competitively interviewed and was appointed as an advanced laparoscopic endometriosis fellow, working with Professor Amar, and she is coming near the end of her 2-year fellowship. So we're very delighted to welcome Nilafor to present on a very, very interesting case with her and Professor Jayaprakash. So Nilafor, if you want to share your slides.
Thank you very much for the kind introduction. I'll just share the slide.
Do you want me to share for you, Nilafor?
Yeah, if you do that, actually.
Yeah, no problem. Okay, can you see that okay?
I'm not able to see at the moment. Yeah, I think something's coming up. Yeah, we can see it. Okay.
Okay, perfect. You just tell me when next.
Okay. A very good afternoon, everyone. I'm Nilafor Noor. As Emily's already introduced me, I am currently advanced laparoscopy trainee at Royal Derby Hospital, and I'm going to present a very interesting case that we did with Professor Jayaprakash on OHVIRA syndrome. So, Emily, if you just move on to the next slide, please. So this is about a 17-year-old girl who was admitted with severe abdominal pain, which was progressively worsening, and during the past 2 weeks, and would be worst leading up to 2 weeks before the periods and after the periods. She had her onset of menarche at age of 15 years, and she'd never been sexually active. On examination, there was a vague mass that was felt in the right iliac fossa, which was very severe, which was very tender, and there were no features of peritonitis. Next slide, please. She underwent investigations, and on ultrasound scan, there was evidence of a uterine diadelphys with the left horn, which was normal, and the right horn was distended with blood, with the AP diameter about 2.7 centimeters. Her right cervical canal and vagina were also grossly found to be distended, and to an AP of 7.4 centimeters, and the right kidney was noted to be absent. Next slide. Something similar to what you could see in the picture there. So this is the ultrasound image of as you can see in here, on the left horn, you can see looks quite normal in the coronal picture here of the ultrasound scan, and the right horn is relatively much distended. And on the picture on the right side, you can see the left, so on the top that you see on the left side is actually the uterus, which is distended, and then on the below is actually the cervix and the vagina, which is grossly distended. Next slide. She underwent further investigations and had an MRI scan, which had a similar picture, showed uterine diadelphys, right horn was distended, most likely with blood, had associated hematosalpinx. And right external os could not be identified, likely because of the gross distension. Left horn was normal, and cervix was significantly compressed and was barely visible. Both ovaries were normal. Vagina, on the MRI, it was hard to tell whether there was a vaginal septum or not. And the kidney was absent to the right side. Next slide, please. So these are some of the MRI images here. This is the sagittal view, starting from the left-hand side, going downwards and back onto the right-hand side top. So left-hand side top picture is showing the left uterine horn, and then as we go down, and basically we're going from left to right here. So the picture on the left lower picture shows the emergence of the distended vagina and cervix down below, above the left normal horn. And then the right lower picture shows again the appearance of this grossly distended vagina and cervix. And then this is leading up to the right uterine horn on the top. And we can just about see an area where potentially could be the normal cervix, which is completely pressed. And then the top picture to the right side shows the distended vagina and the cervix, along with the right uterine horn, which is distended, and you can see a bit of the hematosalpinx on the right side as well. Next slide, please. The same MRI images in the coronal view. We can see the grossly distended vagina here and on the left side, and then in the left picture on the top right, you can see a little bit of the right or a little bit of the left normal horn over there. And in the same picture at the bottom, you can see a little bit of an area which is probably a normal cervix, which is compressed by the distended blood. And then again, when we go a bit higher up, so this is lower down into her pelvis, and we come a bit higher up into the pelvis is the picture on the right side that shows the grossly distended vagina, which is leading up to the grossly distended uterine horn on the right side. Next picture, please. And this is again the axial view. We can see the normal in the left side picture. We can see the normal horn on the left side, and then just about beginning of the blood clot, we can see which is collected in the vagina, and then as we and the uterus, and as we go down, lower down, closer to where the bladder is, we can see the grossly distended vagina, uterus, and a little bit of the tube that is coming out from the right side as well. Next picture, please. Next slide, please. So she underwent an ultrasound-guided procedure. So she had an examination under anesthesia, which showed a thick vertical midline vaginal septum in the upper 2/3 of the vagina. She underwent a hysteroscopy, a vaginoscopic guided hysteroscopy, which confirmed this and showed on the left side, on the right side, there's a blind hemivagina, and on the left side, we could see just on the top picture over there, we can just about see the vagina or doing vaginoscopy, and that is the hymen over there. And then as we're entering in the middle picture is sort of the level of the external and internal os. And then the bottommost picture over there is the uterine cavity with a single ostium over there, the left hemiuterine cavity. There was a very small polyp that was also noted on the near the ostia, which was removed. And then under ultrasound guidance and the assessment from the hysteroscopy, an incision, a cruciate incision was made into the hemivagina on the right side, and to drain the collected blood and clots from it. And we could see under ultrasound guidance the collapsing of the grossly distended vagina and the cervix, and then the uterus as well, and actually to a point where the right hemiuterus took almost a normal shape by the end of the procedure. Next slide, please. So the diagnosis which was established after this was the presence of a high OHVIRA, which is obstructive hemivagina and ipsilateral renal agenesis. She had uterine didelphys, upper vertical vaginal septum, transverse vagina, which was sort of oblique in nature, as you can see in this picture, which resulted in it being obstructed, resulting in the obstruction of the right side of the reproductive canal, and there was associated ipsilateral renal agenesis, which is not uncommon in such cases. Following the surgery, she was discharged on back-to-back combined pills to allow time to heal for her, to reduce the menstruation. And she was followed up about 3 months postoperatively and had a significant improvement in her symptoms. And then an MRI was subsequently repeated in December, which showed her reproductive organs and the size of all the distended hemiuterus and vagina to have gone back to normal. Next slide, please. So just a little summary to conclude. Obstructive hemivagina with ipsilateral renal agenesis is also known as Hurlin-Werner-Wunderlich syndrome. It's a very rare condition seen in about 0.1 to 3.8% only. And the diagnosis may be delayed because they do have one side working, normally functioning uterus, and that can result in normal onset of periods and puberty. And therefore, that her symptoms may be dismissed as normal period-associated pain. The symptoms typically are cyclical abdominal pain, and which gets progressively worse as the blood gets collected and can result in formation of an abdominal mass, very, very tender mass, actually. And there may be a presence of vaginal tenderness because of the bulge of the vagina, which will be very tender as well. And early intervention is at most importance because it reduces the risk of them then developing endometriosis because of the retrograde flow of the collected blood, and also subsequently impact on fertility. There is a chance with pregnancy, there is a more likelihood of having prematurity and malpresentation because of the uterine anomaly. MRI is a gold standard, but 3D ultrasound can also be very helpful. And surgical intervention is the most effective. However, in where surgery is not possible, then hormonal treatment to suppress menses is also an option. Next slides, Emily. Yeah, thank you so much, everybody.